was going to bring that PowerPoint up for you.
Hi, everyone. Just in the name of time, I'll go ahead and get started. Thank you, everybody, and thanks, Ann, for all of the work that the Sandhills team has done to bring this training together. I know that many of you may have already attended a comparable training through another LME-MCO network, or you may have heard my voice yammer away on an earlier Sandhills training. So just to reassure you, if you have heard my voice before and this slide is looking vaguely familiar, you've probably attended this training before, and feel free to redirect your priorities as appropriate. We know that there is a lot going on in the Medicaid space right now, and obviously our key priority within the Medicaid space is to support our mass migration to the Medicaid standard plan managed care model on July 1st. And so we are reaching out to provider groups to talk about some of what we refer to as transition of care protections and safeguards that are in place to assist beneficiaries and related to that, their providers through this transition on July 1st. So many of the slides that I'm going to show you may have seen at this point in other venues, but we do want to make sure you have a basic foundational understanding of what's happening, given that there are so many moving parts and that you all have day jobs, which are very, very important. So thanks for attending today, and let's go to the next slide. So just a couple of qualifiers about what's going to be covered and what isn't. This is not going to be a comprehensive overview of our move to Medicaid managed care. We're not going to be talking about provider reimbursements, or we're not going to be talking about provider contracting, but we are going to provide a summary of the transition so that you at least have some solid insight into what's going to happen on July 1st. We're also going to talk at a high level about the populations that will transition on July 1st. And then we're going to go into some protections, transition of care protections about that for those populations, and some of the supports that we've established as a state in collaboration with our LME-MCO partners and our other partners to make sure that member continuity of care is maintained wherever possible through this transition. We know that in this particular provider network, the concept of the tailored plan is very, very important and something that you all are probably paying very close attention to, rightfully so. But because that tailored plan option is not launching on July 1st of 2021, it is not the priority for this discussion. We are also going to, like I said, not talk about some of the managed care specific dynamics that we know you all are thinking about related to provider contracting and rate reimbursement, rate floors, those kind of things. We're not going to be talking about that. That's outside the scope of transition of care, but we are going to point you, I'm going to point you in the direction of some resources that hopefully, if you have questions, you can be clear on where to go and what resources are available. Next slide. And you can go to the next slide. So just as we are getting into the brass tacks of this transition, we want to remind ourselves that we are working under a much more global vision of Medicaid transformation. And that vision is to improve the health of North Carolinians through innovative, whole person centered and well-coordinated system of care that addresses both the medical and non-medical drivers of health. And so all of the work that's underway right now towards the Medicaid transformation endeavor really works towards this North Star. Next slide. This is probably information you have seen at this point, but we want to make sure that, again, everybody is very clear on the foundations of what's happening on July 1st. So as you probably well know, approximately 1.6 million beneficiaries of the current 2.5 million beneficiaries that Medicaid serves will transition to the North Carolina Medicaid managed care model. They will transition into what's typically known as a standard plan. It's important to know that while 1.6 million beneficiaries will transition, obviously there is a significant number of beneficiaries who will not transition. And I want to make sure we highlight some of those key groups verbally so that you have this in your notes. Key groups that will not transition, and this list is not exhaustive, but people who are dually eligible, People who both have Medicare and Medicaid will not transition into the standard plan on July 1st. So if you're supporting someone who's dually eligible, those members will continue to receive services exactly as they do today on July 1st. If you support children who are currently enrolled in the foster care program, those children will not enroll in the standard plan option on July 1st, and they will continue receiving services exactly as they do today. Finally, as you all probably understand, a lot of people who are currently served by the LME-MCOs and require services that are only available in the LME-MCOs are considered tailored plan eligible members. And those tailored plan eligible beneficiaries are intended not to transition on July 1st. It's important to know that tailored plan eligible beneficiaries do have the option to transition on July 1st. However, they will default to the current service delivery system and continue to receive services through the LME-MCO as they do today, unless they proactively select to transition to a standard plan. For members who are transitioning to a standard plan, they will choose or be auto-enrolled among 5 health plans. We typically refer to these as health plans. You'll sometimes still hear references to PHPs. All of these are referencing back to the standard plan health plans that are listed here on the slide. And so we have 4 statewide partners and 1 regional partner in CCH, and they will be serving regions 3, 4, and 5. Importantly, we are also launching, frankly, what's emerging as a national model with the Eastern Band of Cherokee Indian Tribe to launch the tribal option. The tribal option is probably not going to be fully applicable to folks in your region, but it is important to know that it does launch on July 1st as well. It's a primary care management model for eligible members. And it is, like I said, probably not going to impact a lot of the people you serve, but we do want to make sure that you know it is also activating on July 1st. It is going to be outside the scope of today's presentation. Next slide. So I've already talked about some of these terms, but just to make sure everybody's clear on what we're talking about, you've probably heard a newer phrase known as Medicaid Direct or North Carolina Medicaid Direct, and that is a newly branded term to describe the Medicaid service delivery model that exists today and that will continue to exist after July 1st for services that are not covered by the standard plan. So when we talk about a person being in Medicaid Direct or returning to Medicaid Direct, we're talking about people who will continue to receive services exactly as they do today in the Medicaid fee-for-service model or in the LME-MCOs. When we talk about Medicaid managed care, we're talking about those 5 standard plan health plans that were listed on the earlier slide. Like I mentioned, we sometimes refer to them as PHPs or standard plans, but they all mean the same thing. And when we talk about Medicaid managed care on July 1st, that's what we're talking about. You may hear the term managed care launch or see the term MCL. That is referring to our launch date of July 1st, 2021. Finally, as you all well know, the tailored plan design is very much in implementation phase and but it will not go live on July 1st, 2021. It will not go live until next year. But we want to make sure people are aware of the concept, which is it's intended to provide a comprehensive managed care model for people who have behavioral health needs, IDD needs, TBI, and substance use disorder needs that are not readily addressed in the standard plan option. So the tailored plan model will launch in another year, but it is not the focus of today's discussion. Next slide. So just like we're working toward a vision collectively as the department, we are also working under a vision for transition of care transition of care specifically. So just as a point of reference, when we say transition of care, we're referring to the concept of what happens when a member changes health plans or changes service delivery systems. So we're not necessarily talking about a member who is discharging from a facility back to a home-based setting. We're talking about the migration that people experience when they transition health plans or, again, service delivery models. So as we think about people transitioning to the standard plan option on July 1st, that is going to be a mass transition. We also know that people will be transitioning on a daily basis after July 1st between health plans. And in some cases, they may transition from a health plan back to Medicaid Direct. All of those activities are under the banner of transition of care and under the vision of making sure that as beneficiaries transition between these service delivery models and between these health plans, that they maintain continuity of care and that the providers have diminished administrative burden through the process. Next slide. I have not yet found another visual that better captures the concept of transition work in North Carolina. And so again, as I've already said, members will be transitioning from Medicaid Direct to a health plan on July 1st. And then again, starting after July 1st, people will be transitioning between health plans and in many cases back to Medicaid Direct. So if you think about a member who is Medicaid only, who transitions into a standard plan on July 1st, but then becomes dually eligible, perhaps they turn 65, and they become dually eligible in September or October, that member will transition back to Medicaid Direct. And so as we're developing our transition of care design and architecture, we have to accommodate all of these moving parts and all of the eligibility realities that exist in our state. Next slide. So I've already kind of alluded to this, but there are two distinct phases of transition of care work. As I've mentioned, on July 1st, a lot of people will transition on the same day to a new service delivery model as they enroll in the standard plan option. We refer to the safeguards and practices related to that activity as crossover. So when we talk about crossover, we're talking about the mass transition that will occur on July 1st. As I've already mentioned, starting on July 1st and moving forward, people will transition between health plans. They may have been auto-enrolled with United and would prefer to be with AmeriHealth. They may be with AmeriHealth and need to disenroll back to Medicaid Direct. Those dynamics will activate on day one and moving forward. But we call those transitions ongoing transition of care to distinguish between the mass transition that everybody will experience on July 1st. Next slide. So this slide, as we do these presentations, becomes more and more dated as we move through this process. So many of these activities have actually already occurred. And you all may remember that auto enrollment was extended. But this past weekend, all of those folks who are slated to transition to the standard plan were what was called auto enrolled if they hadn't otherwise picked a plan. And so at this point, those members who are required to transition to a standard plan option on July 1st have had a plan either selected, they've either selected a plan or they have been assigned a plan. It's important to know that members continue to have choice to change their plans as appropriate and as necessary. But everyone who will be transitioning on July 1st, who is required to transition on July 1st, has now been assigned a health plan. As you can appreciate, the July 1st date is a big one. We all want to have that circled on our calendars, as that is the date that these members will change the service delivery model that they use to receive their services, and they will transition into the standard plan option. After July 1st, members continue to have a choice period where they can change their health plans. And again, we'll be transitioning between health plans as their selections shake out. Next slide. So you've probably seen this slide before in some form. It's a really important slide. We want to make sure our behavioral health providers are very aware of it. Basically, this slide reflects those services that will either be available both in the standard plan and in the LME-MCO after July 1st. And those services are reflected in the left column. So if you are providing the service on the left column, you will want to enroll in both the LME-MCO provider network and also the health plans provider network, because those services will be available in both service delivery models. If you provide services on the right side of the slide, it's important to know that outside EPSDT, after July 1st, these services will only be available through the LME-MCO. And as I've mentioned earlier, the LME-MCO will continue to provide services as it does today for the members who remain with them. So if you provide services on the right side of the screen, you are most likely to continue to provide those services within the LME-MCO. Again, just to note the EPSDT qualifier, if a member is eligible for the EPSDT benefit, many of those services may also be available in the standard plan for that particular member. And it's important to inquire with the health plan to make sure you're clear on whether that's the case. Next slide. So we're about to get into the mechanics of our transition of care design that hopefully you will see as reflecting our overarching vision of making sure member continuity care is ensured and also providing supports and protections to their provider networks. Next slide. Just to give you kind of a reference, it's important to know that crossover protections and activities have already started even before July 1st. A lot of the back office and the behind the scenes work is well underway at this point. And we wanted to provide a slide that kind of encapsulates all of the moving parts and assigns it to a timeline that may be helpful for you to have. Next slide. So we want to start with a bit of a public service announcement related to those members who are currently receiving services through the LME-MCO. And so if you are providing services to members, actively providing services to members in the LME-MCO, it's going to be important to make sure you're clear on what's happening here. So as you can appreciate, there are services that only the LME-MCO will provide after July 1st, the services that were on the right side of that earlier slide. And we know that there are a lot of members who currently are receiving those services. The state has been working rigorously for a long time to make sure that through claims and encounter detail, those members are assigned to the LME-MCOs and do not transition on July 1st. However, as you all can appreciate, sometimes there are active services being used where there is not claims and encounter detail to support that utilization yet. The state may not know about it. And so we want to make sure that we have a safeguard for identifying those members who are currently authorized to receive LME-MCO only services, but in the eligibility system have still been identified as slated to transition to the standard plan. So working very closely with our LME-MCO partners, we have been engaging in what we call a rapid identification process, where people who are authorized for tailored plan only services or LME-MCO only services are identified and provided to the state in order for their eligibility to change in order to be exempt from transitioning to the standard plan. We are working very hard to make sure that if people are currently relying on tailored plan only services or otherwise LME-MCO only services, that they don't have a service disruption and transition to a standard plan when really they should have remained with the LME-MCO. So that process has been underway for several weeks now. It has gone very smoothly, and we just want to make sure that folks are aware that LME-MCOs may be reaching out to request provider information on clients or beneficiaries that meet the criteria for being included in this list. We all know that there are services that are LME-MCO only services that do not require a prior authorization, and so we want to make sure that those members are also included. Members who use SACOT, SAOP, other services similar to that. And we want to make sure that those members are also identified. And so Sandhills may be reaching out to its provider network, if it hasn't already, to identify these members and to identify them on the list in order for them to continue receiving services as they do today after July 1st. Next slide. So, Anne, can I hand it back over to you all to provide any context here?
Sabrina, by chance, are you on the?
Yes, I'm on. Yes,
Okay.
I am. I'm on. Thanks, Trish. This is actually information that came out from our IT department. This came out through network from IT, and it's just informing our providers of the process to submit the list of names of members that are receiving SAOP and SACOP services so that they can be sent in on the weekly report for the rapid identification. So the next few slides will show providers specifically how to submit that information.
And I think we can go to the next slide then. Sabrina, is there anything else you want to say on these, or did you just want to illustrate that they're here?
Right. These are just illustrations to show you how to enter the portal. Sandra, if you can go ahead and advance to the next slide. They've provided to show you the drop down information. You can advance to the next slide. This is the reporting information. Sandra, you can advance. And again, at the end of the presentation, there are has questions around submitting that information to our IT staff. Trish, I'll turn it back over to you.
Awesome. So as we get into the mechanics of some of the transition of care work that we have established, we are always working toward the design priorities that are outlined here. And so hopefully as we move forward, you'll see that these design priorities are reflected in the work that we've established. Just as a note, our priority is always going to be that first cell of recognizing the importance of facilitating uninterrupted service coverage. That's always our overarching priority, and all of the other ones really work to support that overarching priority. Next slide. Next slide. So we're going to start talking about some of the mechanics that have been established related to prior authorizations, or service authorizations as they're often called. And we want to make sure providers are very well informed on the protections that are available for those service authorizations that are currently in effect and that will be in effect prior to July 1st. So we just want to make sure you're, first of all, very clear that up until 11:59 p.m. The day prior to July 1st, so June 30th, providers will continue to submit prior authorization requests to the LME-MCO exactly as they do today. So no matter what the member's trajectory is going to be on July 1st, if you have a service authorization request for a member, and that service authorization request needs to be submitted before July 1st, you submit it to the member's LME-MCO. The safeguard has been established, and big thanks to everyone's technical teams for transferring open and recently closed prior authorizations to the member's health plan once that is received, and then to ensure continuity of care. So for those members who transition into a standard plan on July 1st, their authorizations in most cases should be waiting for them. We're going to talk about a few qualifiers that are really important to our behavioral health colleagues, but in general, the authorizations that NC Tracks authorizes and other UN vendors authorize will transfer to the member's health plan, and like I said, be waiting for them when they get there. The health plans are contractually required to honor those open authorizations for services that they cover up to 90 days after launch, unless the authorization expires sooner. If a health plan terminates an open authorization after 90 days, it must issue appeal rights. I want to make sure people see that little double asterisk on the bottom, because in the behavioral health community, 42 CFR Part 2, the federal substance use disorder regulation that governs how information can be shared, it does come into play here. And we'll talk a little bit about how that is going to work. But for the most part, for prior authorizations not covered under 42 CFR Part 2, it's important to know that those authorizations will transfer. And if the health plan is responsible for that service on July 1st, the health plan will honor that authorization according to the terms I've outlined here. Next slide. So we always really appreciate within the transition to care space the subject matter expertise that all of our other colleagues bring. We are not behavioral health experts. Our job is to make sure that the transitions ensure continuity of care regardless of the service that a person uses. So we rely heavily on our behavioral health experts to build the safeguards and the protections and make sure that those are supported for folks who use behavioral health services. And so this protection really reflects one of the North Carolina's dynamics and realities. And that's that if a member is transitioning to the standard plan on July 1st, her unmanaged visit limit under clinical coverage policy 8C will reset to 0. So we know that the unmanaged visit limit exists before a prior authorization is necessary, and those unmanaged visit limits will reset to 0 for those transitioning members on July 1st. Next slide. So this slide is, I recognize it's busy, but we want to make sure that you have some of this prior authorization scenario in one place, or these prior authorization scenarios in one place. And so the first scenario that's outlined on this slide really reflects the dynamics that I just went through. And that's kind of the best case scenario, and hopefully the most common scenario. And just to orient you to this slide, if you look down the middle of the slide, the gold line represents July 1st. The header under the left side of the slide is the members covered by the LME-MCO. So that represents the activity or the time before July 1st. So now in June. The green header on the right side of the slide represents what happens after July 1st, when the member is covered by the health plan. And in scenario 1, this is exactly what I just described on the earlier slide, but this is a case where an LME-MCO generated prior authorization has been submitted and will continue to be covered by the health plan when that member transitions on July 1st. And as I've mentioned, those prior authorizations would be submitted prior to July 1st to the LME-MCO. They will transfer to the member's health plan. And on July 1st, the health plan will be responsible for continuing those open authorizations. Like I keep saying, the authorization will be waiting for the member, and the member will continue to be served under that authorization for at least the first 90 days, unless the authorization is set to expire sooner. In the second scenario, this is a scenario we are working actively to avoid. We want to make sure very few people, if anybody, experience scenario 2, which is why I mentioned the rapid identification process earlier. In this scenario, but it's important for people to understand how this will play out. In this scenario, a provider submits an authorization request prior to July 1st for a member who's transitioning to the standard plan, but for a service that is only covered by the LME-MCO. So it's one of those services that's on the right side of that, the right column of that page that we looked at earlier. It's important to know that the LME-MCO is still going to process it. They're still going to authorize it. And that authorization will technically transfer to the member's new health plan. However, the benefit is likely not going to be available to that member for a service that is not in the scope of the of the health plan. So if that member is not otherwise covered by the EPSDT benefit, the member will lose that service. It's really important, if you're multitasking now, to make sure you're listening to what I say, that if a member is currently receiving a service that is only available in the LME-MCO, and that member transitions to a standard plan on July 1st, it is very possible that service will no longer be available to that member. And we're going to talk about what the anticipated next steps are going to be in that case. But the best way to avoid it is to prevent it from happening at all. And so that is why our rapid identification process with our LME-MCO partners is so important to mitigate the risk of this happening. The third scenario reflects a retroactive dynamic, which may occur from time to time. And in this scenario, the provider has an authorization for dates of service prior to July 1st, so in June, but submits that authorization after July 1st. It's important to know that if the provider, if the LME-MCO was providing the service or covered the service for that member prior to July 1st, the LME-MCO will authorize it as clinically indicated, but will not be able to do so beyond dates of service of June 30th. So it's important to know that the provider will need to resubmit any authorization to their member's health plan for dates of service July 1st or later. Okay, next slide. So this slide is dated, and we apologize that the deck was circulated so early that we haven't had a chance to update this to be more helpful. But we did want to highlight a couple of key points as you're preparing your practice or your organization for transformation and making sure that you have insight into how prior authorizations will work for your particular clients. First of all, the first thing to always check is your member actually going to transition? Again, especially in the behavioral health space, a lot of your clients will not transition to the standard plan, and this presentation is irrelevant. It's important to be aware of that member's dynamic. You may already be aware of it. You may have already requested information from the LME-MCO. The member herself may understand that. But we also want to make sure you're aware that in the NCTRACS provider portal, the information of that member's managed care status will soon become available. The functionality already exists, but the managed care status will be available 30 days prior to July 1st. So starting in early June, you should be able to go into the NCTRACS provider portal and see the member's Medicaid managed care status. At this point, you should also be able to see which health plan they've either selected or have been assigned to. And that will help inform whether you have a dynamic that a member related to supporting a member to transition on July 1st. Again, as I've mentioned several times, July 1st is a date we all want to have circled in red on our calendar. At this time, anyone who will be transitioning to a standard plan on July 1st will do so on July 1st, regardless of the region. Next slide, or excuse me, the next bullet reflects basically what I've said earlier, and that being mindful of when and the dates of service covered by the prior authorization that you need to submit. And also just to advertise, we our housing, we have resources that provide additional information about how to submit a prior authorization to each of the health plan options, and I'll talk about that in a little bit. Next slide. So we recognize that you all have a lot going on right now, and you have things going on way beyond just Medicaid and Medicaid transformation. We know that you're thinking about your clients, you have other payers. There's a lot to think about as you support people to meet their behavioral health needs. And we want to make sure that there are safeguards established so that providers are somewhat protected from submitting a prior authorization to the wrong direction. Importantly, this is not on the slide, but we need to reiterate it, health plans will not accept prior authorization submissions prior to July 1st. So that's a really important safeguard right there. We also want to make sure that providers are aware of what's happening, which is why we're doing so much education on this point. We also are working with all of our vendor partners to establish banner messages that limit, banner messages and functionality that limit the provider's ability to submit a prior authorization that may no longer be applicable for a member after July 1st. So just to be mindful that you will start seeing banner messaging that indicates that whether it's appropriate to submit a prior authorization for your intended member. And finally, we have worked with all of our vendors to establish call center scripts so that call centers can have specific guidance to give providers who may call them with questions. Next slide. Not going to talk a lot about appeals, but we do want to acknowledge that the expectations have been set that if a member is under a maintenance of service or a continuation of benefit, the health plans are required to honor that as they reevaluate a member and make their own determination. If you have a request or a denial for an initial request for services, it's going to be important that you resubmit that authorization request directly to the health plan after July 1st. Next slide. So as you all can appreciate, providers need to understand how payments are going to work. We are not here to talk about the provider reimbursement process. That would be its own webinar. But I did want to highlight a couple of key date dynamics related to payments. Claims for dates of service prior to the member's standard plan effective date, so prior to July 1st, should continue to be submitted to the LME-MCO. Claims for dates of service after the member's standard plan effective date should be submitted to the member's health plan following applicable health plan protocols. So if you have a member who has transitioned and you were providing services to that member before July 1st and after July 1st, the dates of service, the claims for dates of service before July 1st should go to the member's LME-MCO. Claims for dates of service July 1st or after should go to the member's health plan. We recognize that there are a lot of moving parts right now, and we know that you all are all working really hard or likely working hard to contract with the health plans if you haven't already. We certainly encourage you, strongly encourage you to continue that. Health plans, just as a matter of education, are working open networks. So they are certainly excited and motivated to build their network as robust as possible. And if you are a Medicaid enrolled provider, you will be able to contract with the health plans. Importantly, we recognize that that may not have fully been ticked and tied by July 1st, and there are out-of-network provider protections after July 1st. So that if you are an out-of-network provider after July 1st, your claim and your authorization will be treated as on par with an in-network provider. There will not be additional restrictions or limitations placed on you as an out-of-network provider. So it's important to know that that safeguard exists. But again, our overarching hope is that you are contracting with all of the health plans at this point directly. Next slide. So I want to spend a bit of time talking about some of the protections that we have put in place to support what we have referred to as high need members. As you can appreciate, a lot of the high need member populations that we have in our state, foster kids enrolled in foster care, dually eligible beneficiaries, will not transition on July 1st, but we have to recognize that there is still a number of folks who have clinical complexities or clinical vulnerabilities that will transition on July 1st. And we want to make sure we have safeguards in place to support these members. Next slide. So this slide represents some of the gradated safeguards that have been established for the beneficiaries who are transitioning on July 1st. Importantly, there is an incredibly robust data transfer architecture established to support members who are transitioning. And so regardless of the member's clinical complexity, the member's claims history, prior authorization history, pharmacy lock-in data, and in many cases, care plans or assessments will transition to the member's health plan to be in place on July 1st and to inform the supports that that member receives. Again, we've also identified a subset of the transitioning population as high need based on their clinical service uses and different dimensions of how people can be identified. So we'll talk about that here in just a minute. We also want to acknowledge that our LME-MCO partners and our CCNC partners obviously know individual member circumstances far better than may be reflected in the claims history. And we want to give an opportunity for LME-MCOs and PHPs to talk directly about member-specific scenarios or dynamics that, again, may not be fully reflected in the claims. So if a member is at risk of losing housing, if a member is experiencing a volatility at home, other dynamics that may not be readily reflected on a claim can be communicated to the health plan through what we're calling the warm handoff process. Next slide. So this slide is a summary slide, and it reflects the populations that the state has identified as high need. I do want to highlight that red text, which indicates that identified standard plan exempt members who elect to enroll in a standard plan. So what that means is that if a person who would otherwise not have to enroll in a standard plan and is tailored plan eligible and is clinically appropriate to stay with the LME-MCO, if that member proactively chooses to transition to a health plan, that member is considered to be a high need member. And the health plans are required to track and to follow up with these members very, very closely immediately after launch. Also want to acknowledge that in addition to the follow-up that the health plans will be providing, our state team will also be doing surveying and sampling to ensure that services are maintained for high need members, including members who transition who are tailored plan eligible. Next slide. So we want to make sure that as we go through these slides, we have particular notations for how providers may be engaged. So first of all, the communication that we've talked about, the high need communication and the warm handoff process is really an exercise between the member's health plan and the member's LME-MCO. So providers are not expected to participate or to attend. Those sessions have been highly structured and on a schedule that will activate here in a couple of weeks. But we do want to make sure you're aware that this process is happening, because you may identify members that you're like, hey, we really need to make sure that the health plans are aware of this particular dynamic. We expect these to be kind of certainly high engagement needs, urgent priorities, not every person, but certainly want to make sure that providers help inform that warm handoff group wherever appropriate. It's also important to know that, again, 42 CFR, the federal requirement related to how substance use disorder information can be shared between partners, that if a member is covered under 42 CFR Part 2, it is very possible that the LME-MCO may be reaching out to you to get member consent in order to have a briefing with the health plan on their members' substance use disorder dynamic. So just wanted to flag that may happen. Again, we expect that to be a pretty exceptional thing, pretty relatively rare request, but we did want to make sure you knew that might happen. Next slide. So the next few slides we're going to go through very quickly, but basically this just illustrates the different data dynamics that are existing and that have already started transferring between our Medicaid Direct program and our health plans. Next slide. So as I've mentioned, a number of key data sources are already transitioning to the health plans from the Medicaid Direct program. And so health plans are currently receiving claims and encounter data on their enrolled members to help inform their care management prioritizing and to help inform their clinical continuity of care, to help make sure that their provider networks are addressing the members' needs. And so this claims and encounter detail has activated at this point. As I've mentioned, the open and recently closed prior authorizations will also soon activate, and members will start, plans will start receiving prior authorizations both from NC Tracks and from our LME-MCO partners. And finally, in more isolated cases, our CCNC partners and in some cases our LME-MCO partners will start transitioning care plan information or other more member-specific clinical data to the member's health plan outlined here. Next slide. So just wanted to make sure folks were aware of the provider impact on these data transfer dimensions. Again, claims and encounter not intended to have any impact on you all. The open and recently closed prior authorizations, again, should have no impact. In fact, it's intended to be a support to you all. However, we recognize that because of 42 CFR Part 2, there will be an impact for those providers who are providing services covered by that federal regulation, and we'll talk about that in a minute. Again, the warm handoff process and the transition content. If an LME-MCO has questions about the member's circumstance, or if you identify someone who may merit a warm handoff, there may be exchange with the provider related to that. However, again, the warm handoff process is intended to be largely between the LME-MCO and the health plan. And so we don't anticipate minimal provider burden. Next slide. So I've mentioned 42 CFR Part 2 several times at this point, and do want to make sure to qualify that this is not a training on 42 CFR Part 2. We know that if you all are impacted by it, you are already very aware of it. But we also recognize that this is a very unusual time, and we want to make sure that you have the supports you need to navigate the process into managed care, and as we all work to align with the 42 CFR Part 2 expectations. So we wanted to highlight a couple of things. The first thing I want to highlight and really underscore is we are conducting 2 trainings on this particular process. And if you did not attend the one on May 24th, please, and 42 CFR Part 2 is relevant to your practice or to your organization, please attend the one on June 7th. The link is provided here. We want to make sure to note that there are a number of services where the prior authorizations will not transfer. And so if these targeted services listed on this slide, or if you provide one of the targeted services listed on this slide, please be aware that these prior authorizations will not transfer to the member's new health plan. As the training provides, we've provided a workaround so that members can still experience the continuity of care and the 90-day service authorization continuity provision that I've mentioned earlier. But we go through that in more detail on the trainings. And again, please attend the one on June 7th if you haven't otherwise done, if you didn't otherwise attend the Monday one. Next slide. So the last part of our presentation is going to be talking about some of the member and provider education materials available. So this slide is a little bit of a cafeteria style of information. There's a lot of information from various sources in this. Please take what is useful to you and recognize that some of it may not be applicable to everybody. Next slide. So just wanted to make sure that you are aware of all of the educational related resources that do exist within the department now or through our department vendors that can be extremely helpful both to you and your beneficiaries as you prepare for transition on July 1st. The first link here is to the enrollment broker. That is a fundamental resource for members. The enrollment broker is the front door for helping members enroll in a health plan, select a new health plan, get guidance about which health plan. And so we want to make sure that everybody's aware of this resource. We also have the Medicaid beneficiary portal, which provides a web-based resource for beneficiaries on all things Medicaid. And we've provided the link here. The next two, or actually the next three, are the most important for the provider community. First of all, if you are not aware of the North Carolina Medicaid Help Center, please take a look at it. It's going to be a huge resource for people as they orient themselves to all the moving parts. I call it Medicaid Google, and you can submit a question. You can find questions that have already been asked and answered on your particular issue, or you can submit a new question. Those questions are very closely tracked once they hit the state team and will be routed and answered and responded to. So really good resource there. In fact, if you have questions from today's training that you don't otherwise submit to Sandhills, you're welcome to use this resource as well. The next page, the next link is also critically important, and that's the Medicaid Transformation website on the department's website. And it includes what's called a provider playbook, and we'll talk more about that, but that really does serve as kind of a really good one-stop shop resource for information from provider contracting, for contacts with the HMO, health plan, excuse me. And as I'll show you here in a minute, the health plan specific resources about how to submit a prior authorization. As we get closer to launch, and we are very close, it's going to be critical that you orient yourself to the health plan's actual web pages and the health plan specific information. If you need help finding that, it is on the Medicaid provider playbook resource. But at this point, we hope that you've already started those contract discussions and you're already aware of these resources, but it's going to be really important that you're familiar with these resources before July 1st. Next slide. So as you all can appreciate, if we do not ensure transportation is effectively in place on July 1st, member continuity of care can be compromised. And we want to make sure everybody is aware of this resource that is now, or that will soon activate in a couple of days. And that is that if a member who is going to enroll in the standard plan has an appointment that is scheduled for July 1st or after, they can actually call the standard plan in June to schedule the transportation needed to meet that appointment. So we want to make sure providers are also aware that if there is an appointment that you are scheduling with your client after July 1st, that member can arrange for transportation to that appointment by calling their health plan in June. If a member has an appointment need in June, they need to continue calling the DSSs. But we want to make sure you're aware of this resource that, again, will activate very soon, very soon within all of our health plans. Next slide. So again, we appreciate everything that providers are already doing to support their members in this transition. If members have questions about the standard plan option or which health plan they're in, we strongly encourage folks to direct people back to the enrollment broker. They are definitely the best resource for information about the health plans that are available to that particular member. Importantly, the best thing you can do to support continuity of care is to contract, to make sure that your contracts have been established with your health plans to ensure that service continuity is not disrupted for those services that they will cover on July 1st. Next slide. The next couple of slides are some resources, some web-based resources that we have available to support you. The Transition of Care webpage is on the department's website and is a growing list of, is providing a growing list of resources for providers. I do want to give kind of a hot off the press announcement that the 42 CFR Part 2 training that I mentioned earlier that we did on Monday is now posted on this website. So you have the link here, but honestly, if you Google North Carolina DHHS Transition of Care, you should be taken directly to it. So this resource, this page may provide some really important resources that are specific to our transition activity. Next slide. I've mentioned this before, again, under the banner of education, we are making sure that all of our UM vendors have portal messaging, provider portal messaging, to communicate that if a prior authorization is not able to be submitted, why, in order for providers to be able to direct the prior authorization to the appropriate entity. Next slide. Just want to also recognize that there are a number of resources that are available for members, fact sheets that can assist members in understanding the different resources available to them and the different dimensions of what's going on. We have two that we have really worked to draft. The first one is reflected here, and it's basically a one-page guide or a summary guide of how different disability groups are impacted by managed care. So we know this is relevant to your population, and we want to make sure you're aware of this resource. Excuse me. Also want to make sure you're aware of a fact sheet that is on the Transition to Care page, which provides beneficiaries with a one-stop resource if they have questions or issues with their health plan on July 1st. So what to do if somebody doesn't show up, what to do if they're confused about who their doctor is, who to call if they've got questions about their benefits. So just wanting to make sure you're aware of these resources as well. There will be other trainings on this, more global trainings through our partners at AHEC here in the next couple of weeks, but we did want to make sure you all had an insight into what resources existed as well. Next slide. This is the link to the Medicaid Provider Playbook. Again, if you Google North Carolina Medicaid Provider Playbook, you will find it. But we want to make sure you're really aware of the resources available. So if you go to the next slide, I'm going to highlight that. These are some of the topics that are covered in the Provider Playbook, just to kind of entice you and to make you aware of what is available. So our provider engagement team has done an amazing job of building out technical resources and fact sheets that give health plan specific guidance on who to call, how to submit a prior authorization, how do I submit a claim, where do I get more information. And those resources are available through the Provider Playbook and link you to plan-specific contacts and communications that are also going to be supporting your understanding of how the processes will work after July 1st. Next slide. So my last slide before we can probably take a couple of questions is to make sure people are aware of what's going to start happening on July 1st as members transition between health plans. And in some cases may need to transition back to Medicaid Direct. So we can recognize that there are going to be dynamics starting July 1st where a member who is in the standard plan really needs to return or remain with the LME-MCO. Perhaps there is a behavioral health episode that had not occurred yet before July 1st. Or perhaps there was a service dynamic where the member transitioned and didn't mean to. They may have proactively selected a health plan, but realized, did not fully appreciate that they were going to lose services. And so they want to come back to the LME-MCO. As a note, the department is working very closely right now with all of our partners to help communicate this to members specifically. So again, that we have a minimal risk of people losing services, but we do want to make sure people are aware of how to reactivate members transition back to the LME-MCO. And so you all may be aware of what's called the request to stay process. That's in effect now, where a member can proactively raise her hand and say, I'd like to stay with the LME-MCOs. That process exists now, and that process is being reworked so that after July 1st, that member can still raise her hand and say, I really like to return to the LME-MCO now. So we want to make sure that providers are aware of this process. More information to come. This is not a process that's managed by Transition of Care. But we know that it's also interconnected. We at least wanted to make sure you were aware of it through this presentation. I'm going to transition to the next slide, which I imagine will be a Sandhills question and answer slide. So just wanted to thank you for your time today. I'm sorry that the timing worked out where I'm going to need to drop here in a few minutes, but I will be happy to stay on for a few minutes for questions. So Anne, I'll turn it back over to you.
Okay, so okay, so there I am. So we do have questions in the chat, and it appears we are not going to be able to get to those questions. Do you have time to take some of them?
That's what I said. I'm happy to take a couple. Yep.
Okay, so right. So let me get. So some people were asking if this information would be available, and we will be posting this on our website. So that's a quick answer for that. Will a sister or caregiver that lives in the home with the patient have to clock in and out at the home or in a mobile app? Oh,
I think that's a question about EVV, and I can't answer that. I'm sorry.
Okay. we will have to come back to that. Well, there it is again. Does a provider know if their outpatient therapy clients are standard or tailored plan?
Yeah, that's a really important question. I'm glad you reiterated it because I mentioned it, but it was fast, and I know that there's a lot of information in this slide, or this deck. So thank you for asking the question. So in NCTRAC's provider portal, in a couple of days, like next week, you should be able to go into the NCTRAC's provider portal and look up the recipient information, and you will see information about that member's managed care status, and you will see that member's assigned or selected health plan. So we are working to make sure that we have the screenshots that are appropriate to give to our LME-MCO partners, and we will also post them on our transition to care webpage, so you have a tutelage on how to do that. But if you go into the provider portal starting next week, you should be able to see that a member has been, whether the member is going to be assigned to a health plan, and the health plan that the member has been assigned to. The functionality is set up to be 30 days in advance of July 1st, which is why I keep saying next week.
Okay.
A great question.
Do you have any anything you can say about the state taking over provider credentialing and when that might happen?
I'm sorry, I can't. That's outside the scope of our work. But again, I strongly encourage you to look at that Medicaid Help Center. Again, the Medicaid Google, because that is a clearinghouse resource for all the questions related to transformation, and is frankly available for questions not related to transformation. So I strongly encourage you to submit that question directly, and it may have already been answered, and you may find it on the webpage. So.
Okay, will DHHS provide training for clinicians in negotiating reimbursement rates with the PHP plans?
I can't speak to that. My hunch is no. The department really doesn't. My hunch is that we would not see that as an appropriate role for the department. However, again, I would encourage you to look at the Medicaid Provider Playbook, because I think there will be good information about, as you engage in contract discussions, some resources that may be important for you to know about. And Anne, with that, I think we're going to have to close the questions, but I really appreciate everybody's attention. I know how hard this provider group works. I used to be a provider of supporting folks with IDD. And I really appreciate your taking time out to support this effort and to understand it as we all move forward. So, Anne, thank you for your hospitality, and I will wish you all a good afternoon.
Trish, will you, before you head out, will you
Sure.
please remind people of how they can get their questions answered?
Yes. So Sandhills, I believe, has an inbox that they have set up, as LME-MCOs have. And again, the other option would be to submit the question directly to the Medicaid Help Center resource that I provided earlier.
Very good.
Love that.
All right. Well,
Thank you all
so much.
Bye-bye.
Okay. So for the individuals who are still on this presentation, we will be posting, this was recorded, we will be posting it on our website. So you will have the slides as well as the discussion that went with it. I do apologize to those of you that had questions that we could not get to. So hopefully you can follow the instructions that Trish provided to get the answers to those questions. Is there anything from any of our MCO staff that we need to say as we close out? I think we're done. Okay, well, thank you for being with us. Please ask questions as you have them, and we hope you have a good day. Thank you so much.
Thank you, Anne.
Thank you, Anne.
Thank you. You're so welcome. Bye-bye.
Bye-bye.